At the 11th Annual Academic Conference of the Infectious Diseases Specialty Committee of the China Medical Education Association (IDSC) 2025, Professor She Danyang from the General Hospital of the People's Liberation Army delivered a lecture entitled Early Diagnosis and Treatment of Invasive Fungal Infections in Critically Ill Patients based on the FUNDICU Guidelines. The presentation covered three key aspects: current epidemiological status, challenges and updates in early diagnosis, and treatment strategies. First of all, let us examine the current epidemiological status. Data shows that the overall incidence of invasive fungal infections in intensive care units (ICUs) is approximately 16.4%. Significant differences exist between regions. The incidence can be as high as 22.5% in Africa, while it is 9.3% in the central southern United States and 17% in Asia, Middle East, all higher than the overall average. In severe cases of invasive fungal infections, Candida and Aspergillus are the main pathogenic fungi, with invasive candidiasis accounting for 14.7% and invasive aspergillosis accounting for 1.4%. Patients of all types face the risk of Aspergillus infection. The incidence of invasive aspergillosis in the ICU is 0.3 to 5.8%. The incidence of chronic obstructive pulmonary disease (COPD) in the ICU is 0.4 to 7.4%. The incidence of IA in cirrhosis with respiratory failure 1.8%, 14%. And the incidence of severe COVID-19 IA in the ICU is as high as 28.1%. Furthermore, mucormycosis should not be overlooked among invasive fungal diseases in critically ill patients. The global incidence of mucormycosis ranges from 0.2 to 140 cases per million population. 37% of mucormycosis cases are diagnosed in ICU patients, and the incidence of COVID-associated mucormycosis in ICU patients is as high as 0.3–0.8%. The diagnosis of invasive fungal diseases in ICU patients is challenging, as reflected in the following three aspects. First, host factors. According to the EORTC MSG definitions, the majority of ICU patients lack the traditional host factors and risk factors for invasive aspergillosis. Strict interpretation of these criteria increases the risk of underdiagnosis. Second, clinical and iconography findings. Clinical manifestations in ICU patients are often nonspecific and are frequently accompanied by underlying diseases, which can confound imaging results. Moreover, obtaining high-quality pulmonary imaging is often challenging. Third, mycological evidence. Histopathological evidence is difficult to obtain, resulting in low rates of proven diagnosis. Positive culture results are difficult to distinguish between fungal colonization and invasive infection. Non-culture diagnostic techniques are not accurate. The seropositivity rate of GM in airway invasive Aspergillus infection is low, and mucor infection lacks corresponding fungal markers. In 2024, three European academic organizations, ESGCIP, EFISG, and ESICM, jointly developed and published invasive fungal diseases in adult patients in intensive care unit. 2024 consensus definitions from ESGCIP, EFISG, ESIC, ECIPM, ECMM, MSGERC, ISAC, and ISHM. Compared to previous standards, the new changes to the FUNDICU consensus diagnostic criteria are as follows. For invasive candidiasis, the possible diagnostic category is no longer included. Host factors are no longer required for the clinical diagnosis of invasive candidiasis. Non-culture-based diagnostic techniques are not considered mycological evidence for clinical diagnosis. In candidemia, there is a general issue of low positive predictive value and high negative predictive value. The application value of non-culture diagnostic techniques in the diagnosis of invasive candidiasis in critically ill non-neutrophilic patients needs further research. The value of non-culture diagnostic techniques in exclusion diagnosis is greater than their diagnostic value. Blood culture can only be used as a diagnostic criterion for candidemia, but not for invasive candidiasis. For eye, mediastinal, or abdominal infections without perforation, candidemia can serve as a mycological basis for the clinical diagnosis of invasive candida. For patients with classic host factors for invasive candidiasis, the EORTC MSG 2020 criteria are recommended. The changes in diagnostic criteria for bronchial aspergillosis and invasive aspergillosis in ICU patients are as follows. The definition and the criteria for possible diagnosis will no longer be set, and more stringent standards will be used to ensure the comparability and reproducibility of clinical studies. Infection-related clinical symptoms, signs, have been added as a prerequisite for inclusion in the diagnostic evaluation. In terms of host factors, greater emphasis is placed on ICU-specific host factors. For ICU patients with classic host factors for invasive mold disease, the EORTC MSG 2020 criteria are applied. In terms of clinical evidence, the requirements for characteristic iconography changes are simplified, and emphasizing the importance of bronchoscopy in detecting airway mucosal abnormalities in the diagnostic process. In terms of mycological evidence, the positive cutoff value for BALF-GM is slightly adjusted. Serum GM index value is greater than 0.5, and/or BALF GM is greater than or equal to 1, serve as one of the mycological evidence criteria for clinical diagnosis. This concludes the current session. Please continue to follow Dynamicer on related platforms for more exciting content.